So this afternoon, I wanted to chat a little bit about healthcare. And you brought up an interesting question or point about all of us being consumers of healthcare. And especially in the U.S., not only are we, as we go through this presentation, what should be clear is that we're consumers in so many ways that we don't even understand that we're consumers of healthcare in the way that we spend our dollars. And so, one of the questions I wanted to ask is, would you knowingly pay the highest prices for some things versus pay the lowest prices in the world for other things? Have you ever thought about the fact that in the United States, we actually have this luxury that we pay about the lowest prices for anything? Fuel, cars, food. You pick anything you want to that's a commodity. And you realize that the U.S., we pay about the lowest prices in the world for all of those things. I was in China a few years ago, and I ended up paying 3 times as much for some clothing that I could have bought at Target that was made in China, in China for the same clothing. And if you ask yourself, well, why is that in China, where these things are manufactured, they could be so much more expensive than in the United States? Well, it's a simple reason, right? We have a highly competitive environment in the United States for these goods and services. So the benefit that we get from that is we pay the lowest prices for pretty much everything, except one thing, for which we pay the highest prices in the world. Well, how about if the price doesn't have any correlation to the underlying costs itself, right? When we talk about things in a free market, and one of the benefits of competition is that it also drives both profit and inefficiency out of the system, ultimately resulting in lower prices, which are good for all of us. But what if the goods had absolutely no connection to the underlying cost itself? And what if this industry actually makes more money the more inefficiently that it runs? And what if this industry actually benefits from escalating prices within the marketplace? And what if this industry fixes pricing in the marketplace? What if this were an industry that not only fixes prices, but there's really no transparency around what that money is being spent on? And on top of that, what if this industry generally lacks competition? So let's talk, maybe it's the travel and transportation industry. And if it were, well then, a cheap motel room would be about $6,000. You would pay $600 out of pocket, and your employer would be paying about $5,400 for your cheap hotel room. Well, what if it were the automotive industry? Well, then there'd be about 1 or 2 car dealers within driving distance of our houses, and you wouldn't be able to figure out how much that car costs until after you bought it and got home. What if it were the consumer goods industry? Well, then a TV would be about $25,000. This TV right here would be about $25,000, and every year as production went up, the cost or price of the TV would go up. And if it were the public transportation industry, well, in that case, then we couldn't have any sort of public transport. We'd need taxis. And these taxis would need to be driven by pilots, right, who are trained pilots. And we'd have a shortage of pilots because the unions wouldn't allow us to train any more pilots. And if it were the fast food industry, well, then a Big Mac would cost anywhere between $3 and $36. You would have no way of knowing before you got to the McDonald's how much is that Big Mac going to cost. And you would have absolutely no understanding of, well, how much does it cost to make a Big Mac? And that is a picture of American healthcare and some of the struggles that we face if you were to apply the way that American healthcare works in other industries. So the real challenge that we have, really, that is our national challenge, it is everybody's challenge, and not necessarily for just the folks in healthcare, but everyone in America's challenge really is making healthcare affordable. So I'm going to talk a little bit about what that means, what some of the symptoms, if you will. I'd like to show you some facts and data around the assertions that I'm making to talk about why we feel that way. And then also talk about, well, what are the ways that we can think about solving, or what are the problems that we should be solving? So the vision really is to make healthcare affordable. Now, if you were to ask, what does healthcare being affordable mean? It does not mean that people can afford to buy health insurance, right? Because every time we usually think about affordable healthcare, we're not thinking about the goods and services that make up healthcare. We're thinking immediately of, can people afford to buy insurance? And the question that we should be asking isn't, can people afford to buy insurance? The question we should be asking is, why aren't healthcare goods and services, and why are they any different from other goods and services? All of us buy expensive things. We buy cars, we buy houses, We buy all sorts of things that are actually pretty expensive when you think about it. Why is it that when it comes to healthcare suddenly, we can't afford to buy healthcare products and services? And why that matters is that, if you look at how pricing is set in most economies, pricing is set by factors of what people are willing to pay for something. And when things like third-party payment come into play, it really alters the landscape. So, for example, we have a lot of comparisons of countries like India and all these things about their healthcare systems being better. Well, if you put aside their healthcare systems, one of the first things you'll notice in all of these developing countries, for example, is that healthcare products and services cost less, which is usually the comparison that's made. But if you ask why do they cost less, well, it's because the pricing is set by what the average person is willing to pay in those geographies for those products and services, not by third-party payment. So let's talk about unsustainable growth and why everybody in the room should care. On your left, you see sort of the $14+ trillion of incurred debt that we talk about as the federal debt. And that debt is a thing that all of us are always talking about. The piece that nobody's talking about, really, or very few people are talking about, is if you were just to add up the unfunded liabilities, or net present value of the unfunded liabilities that we have, just in two healthcare categories, of Medicaid and Medicare, that's over $50 trillion of unfunded liabilities that we already have. Now, because of the way that the government is not required to quote-unquote put on their books any unfunded future liabilities, nobody in Washington is really talking about that. But why should everybody in the room care? Well, because all of us will outlive every politician's term in Washington. And as a result, we should care because that boat anchor is something that all of us are going to pay for in our lifetime, and our children. So, if we look at OECD, a lot of folks have, when we talked a little bit before about healthcare spend being, the United States having the highest spend in healthcare, this is a chart of OECD countries. As it turns out, we're about 2x the OECD average when it comes to our per capita spend in healthcare. So by far, we blow every other country in the world on healthcare costs. Now, one of the questions that a lot of folks have asked is, well, why don't we move to a single payer system or a single delivery system like in many of the other countries outside of the world? The question I'd ask is a different question. The question I'd ask is, if you were to go to Europe, for example, which most of these countries are, which are 40, 50% lower than the United States, compare the cost of all of the other commodities to healthcare, and you'll find that in Europe compared to the United States, all of those other commodities are almost 2x plus higher than the United States. And ask yourself, well, in those economies, healthcare is on par with all of the other goods and services within those geographies or OECD countries. In the United States, we're an order of magnitude lower on most commodities, or 2 to 3x lower on most of the commodities compared to those countries. And the question I would be asking isn't, can we do as well as the OECD countries? The question I'd be asking is, why can't we do as well as we do with every other commodity, relatively speaking, for healthcare in the United States? Not, can we meet the bar of OECD countries? And then, of course, since we pay more, our expectation, of course, is that we're going to get more. Right? So we pay the highest in healthcare per capita, pharmaceutical, annual out-of-pocket, we're number 2. So what do we get for that? Well, we're number 1 in obesity in the world. We are number 26 in life expectancy. And we have the honor of this past year, we dropped another 4 points from 37 to number 41 in infant mortality. So obviously there is a disconnect between what we're spending and what we're actually getting as a result, or the return on that investment. So the whole question is, well, why should we care? Well, let's talk about that. Where does the money come from? So a lot of times we talk about the spend that we have in healthcare, and we talk about it being a large number, 2009, roughly $2.5 trillion. The piece that we did is we tried to figure out, well, where is that money coming from? Right now, is it taxes or is it something else, right? It really falls into 2 buckets. It comes from employers, where you see the bucket on the top, where they spend directly for healthcare. The other piece that's in there is sort of our estimates on the tax burden on profits, for example, that are taxed, and what the healthcare piece of that is. Usually that just goes into a bucket called taxes. And as a result, it's this black box that none of us really cares about because it's a black box called taxes. And it's a line item in our salaries, for example, that we don't really pay attention to. So what ends up happening from that line item that we don't pay any attention to is about 12% of that tax bucket, our corporate taxes, and about 88% of it roughly are individual taxes. And the reason why, originally this chart used to say employer and consumer, and we changed that to employee for a really simple reason. Last year we flipped, or we're very close to the 50% mark on federal income tax filers who actually paid federal income taxes. So as you actually look at who's paying these taxes to, it's not linear. It's actually not very highly non-linear in who are the folks who are actually paying the costs associated with healthcare. And so primarily the people who pay for healthcare are employers and employees. Because if you're not employed, you're probably not bearing the brunt of the cost for healthcare. So if we ask the question of how does the money flow? There are a lot of misconceptions, for example, about where the dollars are retained. When you look at a traditional insurance plan, whether it's individual or small business, basically aggregates dollars from individuals or small businesses or on behalf of those individuals. And it aggregates those dollars. And the insurers typically only retain about 10 cents on the dollar. Okay, with the medical loss ratio requirements for the large insurers at about 90%, that means that they have 10 cents on the dollar, which includes their profits, their transactional costs, and everything else. 90 cents out of every dollar, even in the individually insured markets, goes in that ballpark, goes to providers of healthcare. Now, if you were to ask yourself, hey, this is a business optimization problem, right? Which is that if I need to get money out of the system, where would you start to look for money? Would you start to look at the 10 cents out of a dollar? Or would you look at the 90 cents out of the dollar? Now, if you were to look at self-funded plans or self-insured employers, which are the majority of most of the employer spend, and probably most of you are in some form of employer-funded plan where your employer actually pays about 80 cents on the dollar. You pay roughly 20 cents on the dollar. Those dollars are pooled, and you have what's called a third-party administrator. So your insurance company that you think of as your insurance company is actually not an insurance company. They actually act as a third-party administrator of funds on behalf of your employer. So they transactionally pass through the payments that you actually incur. So the liability for every claim that you make is with your employer. It has nothing to do with an insurance company. And in those cases, it's roughly on the order of 3 cents per dollar that's actually retained by the third-party administrator, and about 97 cents on the dollar that actually makes it to the providers. Now, if you've been following healthcare reform and a lot of the rhetoric, whether it's in Washington or from a public perspective, the focus has been on the insurance industry, right? The focus is on the insurers are the ones who should be able to control the rates downstream. The fact of the matter is, it's about the follow the money principle. You only have control over the dollars you retain, ultimately. And if you're not retaining it, well, probably someone else downstream that's actually controlling those dollars. And the question of where does that money go? The majority of those dollars go to physician and clinical services and hospital care. Those are the two big buckets. And they've got a whole bunch of other buckets, and we've consolidated some other provider side. But ultimately, if you looked at this and broke it out, it goes to people who provide products and services in healthcare. And if you were to ask, and if you were to think about that for a second, you're like, well, that's not surprising. That's what you would expect, right? Because there are products and services being delivered, and that's what we're paying for. And this goes back to every other problem that we deal with fundamentally. It's a supply side problem, right? The suppliers themselves who are providing these products and services. That's where the money goes. So, I don't know if, I think everyone's probably heard about the Occupy Wall Street demonstrations and things that are going on. One of the biggest complaints that the folks who are occupying Wall Street have is about inflation-adjusted wages and how they've dropped over the past 50 years. So if you were to actually look at inflation-adjusted wages, they're absolutely right. It has dropped over the last 50 years. Now, if you were to add back to those inflation-adjusted wages how much we're paying excess in taxes and direct spend on healthcare, you find that we're actually slightly flat to increasing, right, on the average wage over the past 50 years. The only thing we've really done is we've traded dollars, and our employers are spending more on healthcare on our behalf. So we've given up our bonuses, we've given up our raises, and we've given up everything without realizing that those dollars are now on our behalf being spent to healthcare providers. And I'm sure most people would rather have those dollars back in their pockets to decide what they want to do with it. So if you were to look at a family, with a salary of $85,000, in 2010, if you were to include both sides. Now, the reason why you, as an employee, don't see that is if you're an employee, is that, well, employers also pay taxes and things on their side that you never see. And so those are all healthcare expenses that are incurred on your behalf that you're not even aware of. So if you know, our attempt to quantify that, it ends up being almost $20,000 for someone who makes an $85,000 salary in just healthcare spend alone. So what does it take out of your company? Well, you know, Howard Schultz is smiling in this picture because, you know, he's making the point that he spends actually more on healthcare than he does on coffee beans. And their primary business at Starbucks is coffee. And I think that if he actually realized that he's off by a factor of 2, he wouldn't be smiling. And that's because he hasn't included what the indirect costs for healthcare in the form of taxes and other things that they're paying, as Starbucks as a company is paying, in that. That's only direct spend that he's aware of. Because all of the other money is below the line, so it's never accounted for as a healthcare expense. And then what does it take out of our country? And this is a slide that should matter to everybody in the room, everyone that's in higher education, everybody that cares about the future of America, which is we're spending more and more of our money, which is the brown area under the curve, if you will, on entitlement spending. And spending which ultimately has zero return on that investment for us as a country, both in the short term or in the long term. And so why this should be troublesome is that we're becoming globally less competitive year over year. And what that does is not only does that put us behind the 8 ball today, it sets us back even further as we look into the future. And the problem only gets worse as we spend more on entitlement programs and debt service rather than on things that have a positive return on investment. And those things could be research and development, it could be infrastructure, it could be all those things that we have any form of return on investment. And this chart should concern everybody as an American citizen. Another way to think about this also is when we spend roughly 18% of our GDP on healthcare, is that, remember a few years ago everyone would make fun of General Motors because they had this pension and healthcare liability that jacked up the price of every car by $2,000 or $3,000, and everyone thought that was funny. Well, the markets fixed that for General Motors, but now you can think about the whole U.S. economy having the same healthcare tax on every product and service that we sell. So as a result, that also makes us globally non-competitive in a global marketplace. And so let's talk a little bit about, well, what are some of the facts? What's actually happening under the hood? One of the things that we decided to do was we've seen a lot of studies and things that look at sort of top line, how much do we spend, where should we cut? And the government seems to take a very much a top-down view, for example, of healthcare spend. So we asked a different question. Well, what are the products and services? If this were a business and we're optimizing a business, we'd be starting from the bottoms up. What are the products and services that make up what we call healthcare? Right? What's the pricing distribution? What's the frequency? What are those things that are commodities? What are those things that we can actually optimize? And so we decided to look at it from a bottoms-up perspective. And so one of the interesting things that we found was that 1 out of 2 reasons in California that you go to a hospital isn't for a hip replacement, isn't for heart surgery, isn't for any of those things that we traditionally think about. It's for something really simple called labor and delivery. And out of that 50%, about 700,000 of the labor and delivery are normal childbirth. Mother and child went home, fine. There was no quality question. Both of them were okay, and it was coded as a perfectly okay event. So we can't argue about quality. We can't argue about any of those things that could affect a lot of the discussions that we have when we talk about more complicated things. And we could also argue that labor and delivery ultimately is a commodity. High frequency, well understood problem. Most countries, they don't have health care even involved in the process for labor and delivery, and it's not an illness. So this chart shows you, the blue line is in any sort of, if you were to look at the supply curve, the blue line is what you would expect as supply goes up, price goes down. Price reaches some point, it could turn the other way depending on if there are constrained resources on the other end. Every one of those spots that you see on there, those orange spots, and these are orange and blue for a reason. And so that each of those orange spots up there, represent the average price of labor and delivery at a California hospital and the number of discharges at that average price. Now what should shock you is that you look at the spread and you see there's a spread of between $4,000 to $40,000 for a normal labor and delivery. And now think about this for a second, for all of you who've gone through labor and delivery. Who does the labor usually? Right? And this is only hospital side charges. It doesn't include physician side charges. It's hospital side only. So you've got a nurse who spends maybe a couple hours total out of their total $120,000 a year salary amortized across, whatever length of the year is. And you've got a bed, you've got a room, you've got a couple of maybe fetal heart monitors and things. And you ask yourself, hey, if I were to come up with a bottoms-up construction on what labor and delivery should cost, you probably could construct a model at which every woman in California got to go to the Ritz-Carlton for a couple of days, had a baby and went home, and it would cost less than $4,000. And the spread on this is between $4,000 and $40,000. And you notice that out here, at about $36,000, this is about 11,000 births at $36,000. And you ask yourself, hey, how could there be a 10x difference or spread on the price of something that's a commodity? It's the highest frequency procedure in California. So we also fit that line, and unfortunately the line goes in the wrong direction. And you have to ask yourself why the line goes in the wrong direction. So we, looked at, well, maybe it's constrained capacity. We don't have enough beds at the lower prices, and that's what leads to price inflation, if you will. We found that we had plenty of beds at any price point. And well, what's again interesting about labor and delivery is that if you run out of a labor and delivery bed, you can just use a regular bed and you'll be fine, right? And then we also looked at geographic correlation for economic rents, labor, goods and services variations across California. And you see a couple of interesting things on this chart. One, you see the red corresponds to the highest prices, blue corresponds to the lowest prices. It seems that rural areas have the best pricing in California for labor and delivery, not urban areas. Right? And you also see that the variation is 1,000%. So the labor, rent, any of those things really can't explain the differences across these geographies. Right? You also find that where you find the highest amount of red are where there are high concentrations of single providers. So we looked at maternity, then we thought, let's look at drugs to see if we see any sort of spread on the pricing of drugs, because when you start talking about labor and delivery, we could argue about cost differences. Maybe there's a factor of how people feel about which hospital they want to go to and some other things that influence, not that they're necessarily related to the cost, but there are other reasons why people might choose one hospital over another. But we figured, well, one drug over another, why should anybody care? Right? No one's really going to make a choice to pay more if it's the same drug, right? I don't think anyone is emotionally attached to where we buy our drugs from. And so we looked at a really popular drug. This is actually simvastatin, very common hyperlipidemic. And what we saw was a 14x spread on, this is actual data from last year. This is actually our data, McKesson's data from last year. It's McKesson employees. So it's not extrapolated, but it's actual data on claims of what we actually paid. Same drug. It shows a 14x spread depending on where you picked up the drug from. Okay, and this is a commodity drug. It's not a single source. It's not any of the above. A commodity drug. So we also looked at a couple of interesting data points for you. So this shows you a receipt from Walgreens. Now, the thing that you should note about this receipt is, how much does it say the drug cost? It told you that it cost nothing. What does that do to a consumer when you walk in and people give you things for free? Right? And how does that help in building loyalty when people are providing you things for free? Now, if you look over on this side, you see in the really small print over here, your insurance saved you $59.99. This was an employer-sponsored plan. So there was no insurance. It was your employer who got bilked out of $59.99. Now, you'll also notice that in this case, the employee paid nothing. It was free. The employer paid $60 for that drug. And that employee could have driven 4.5 miles, and on that same day could have paid $4 cash for exactly the same thing. Okay, and the total cost would have been $4. So when we start thinking about problems, often, this is up here for a reason. There are about 60,000 drugstores in the United States, okay? And there are about, 13,000 McDonald's. When couldn't you find a McDonald's when you needed one? Has there ever been a situation that you couldn't find a McDonald's? And ask yourself, why do we have 6 to 7x more pharmacies in the United States? And these pharmacies are profitable. If these pharmacies are profitable, and any one of us can look at that and say, hold on, there were way too many of these, what does that tell you about margin and inefficiency within this industry or supply chain, where you can have an excess capacity of 7x or 6x, and they're profitable? And let me ask you another question. You remember 4 or 5 years ago, there was a lot of press around the fact that we had a shortage of pharmacists? So what you need to ask yourself is, what was the real problem? Was it that we had too few pharmacists, or we had too many pharmacies? Right? Depending on the problem, you would solve those 2 problems very differently. And each one of those would have very different economic impacts on which option you chose. And so we also looked at some simple things like, well, if you were to pick an alternative pharmacy in the US. So on average, anywhere in the United States, if you were to pick a pharmacy where a pharmacy exists, there are 90 other pharmacies within a 10-mile radius of any pharmacy in the US. And we then looked at, well, what are some other commodity things that we could look at? Maybe it's just drugs and labor and delivery. By the way, we looked at stents, we looked at a whole bunch of other things also, hip replacements. And by the way, you see exactly the same type of 10 plus X spread on the pricing associated with those things also. It's not limited to labor and delivery. It's pretty much every procedure that we looked at, we saw the same sort of numbers. If you were to look at this, I don't think anyone in the room is going to argue that any of these is not a commodity, right? And look at the spread. Stanford Medical Group, $16 for an immunization. Palo Alto Medical Foundation, $85. How could there be a 4 or 5x spread on the cost of an immunization? And we're not talking about Joe's Podunk, we're talking about Stanford Medical versus Palo Alto Medical Foundation. And as you look at every one of these categories, you see there's a huge spread. And by the way, these are not the lowest price or highest price in any category. This is just the comparison of a sample set. Right? In each of these, you can find other ones that are lower and other ones that are higher in each one of these on the board. Okay. And so the interesting thing that we saw was, for example, when we saw a bigger correlation was higher pricing in general seems to be characteristic of large provider chains that have very little competition. For example, Sutter Health in Northern California. They own the majority of beds in a lot of regions. And as a result, there is no competition within any of these environments or these regions because healthcare ultimately is local. We have to be able to get to our healthcare provider. And then when we went back and asked the question, all right, we've seen all of these variations, for example, what's wrong? Why? What's going on? And we came up with 3 reasons why we see this sort of variation. But the umbrella that you want to think about is ultimately this issue is about the lack of competition within an industry. Because in a competitive industry, not a single one of those things that we showed about any one of those procedures, drugs, products, or services could ever occur in a competitive industry. Because a competition would prevent that from occurring. So we've got industries that are highly non-competitive. And if you want to go back and ask, if you walk away with one thing, right, that you can relate back to what's the problem with healthcare in America, it's not what Washington's talking about. It's the lack of competition and the structural issues that allow that lack of competition to exist. And if we want to fix things in America, the fastest way is not to put in electronic health records and a lot of the other things that we're talking about. The fastest way is to actually drive or allow competition to occur within the healthcare industry. And if you think about it, when we talk about healthcare, a lot of us sit around thinking about, hey, what's broken about healthcare? How many of us sat around worrying about, hey, what's broken about the American auto industry? I don't think any of us did, right? Because we just chose to buy with our wallets. We chose to buy BMW or Honda or whatever else we wanted to choose. And we didn't want to pay the premium associated with an inefficient delivery system. But when it comes to healthcare, all of us are sitting around in Washington and other places coming back with, it must be this, it must be that, it must be this. And we're not asking ourselves, well, why are we treating this differently than every other industry that we've been able to optimize within the United States? And what do we use to optimize all these other industries? So number one is cost detachment, right? Third-party payment. Why that's a problem is that all of us spend other people's money differently than we spend our own. And you don't have to think about a healthcare example. Go to Wall Street, go to anywhere, go to your own expense report. You know, you go to any factor in life and you realize that you probably spend other people's money differently than you spend your own. And so there's a cost attachment problem when it's somebody else's wallet. That being said, even if you have the problem of spending other people's money, when you go to a car dealer and there's something wrong with your car, do you expect that the mechanic is telling you the truth? Do you expect that what's wrong with the car is actually what they're... I mean, they may not be, they may be lying. But is it fair to have an expectation that they're telling you the truth? Is it fair? Because you're not an expert on how cars run. The person who's a mechanic is the expert. They're telling you what's wrong with your car. And in the same way, do you have an expectation that they're not price gouging you? And that they're getting you a fair price on what it would cost to fix that car? You wouldn't expect to see a 10x variation from this dealer to this dealer, or this shop to this shop for the same thing. So why do we have lower standards for doctors, physicians, and the healthcare industry than we have for the folks who fix our cars? Because they're allowed to do these things, and none of us is upset, where we'd be pretty upset if the auto mechanic charged us 2x more than the auto mechanic next to us. So that doesn't remove the responsibility from providers to be able to understand, am I providing the best quality delivery in the most efficient way? The second thing is that we think, which is a real large structural problem, is that we have a non-level playing field because most of the providers of healthcare services in the United States are not-for-profits. And as a result, if you think about competition, well, competition as a driver for optimization within our economy works because we primarily have for-profit companies. And whether they're private or public, they're still for-profit. The problem that we have within our country is the same mechanism that we use of competition, we actually allow companies to insulate themselves against competition by becoming not-for-profit chains and hospitals. In Northern California, for example, you see there are many news reports talking about both in Southern, Northern, after healthcare reform came about, you're finding a large amount of consolidation of provider systems and everything across the United States. If you were to go back and ask the question of, would the Federal Trade Commission have allowed that consolidation to occur if these had been for-profit companies? The answer to that is generally no, because it removes competition from most geographic areas that these providers play in. And so using a not-for-profit then allows you to do things that you wouldn't be able to do in your normal competitive marketplace.
What does not-for-profit mean?
Not-for-profit really means it's a tax code. I mean, the benefits to you if you're a not-for-profit are that, number one, you're exempt from income tax, which is the primary issue. And more importantly, that's not as big of an issue because you could be a for-profit company, for example, and just not make any money year over year, and you would still look like a not-for-profit company. The main reason why you want to be a not-for-profit is that you're shielded from most of the anti-competitive laws because even the Federal Trade Commission rarely goes after not-for-profit companies, or not-for-profit hospitals. There's also the advantage that we as people have a notion that for-profit is actually a bad thing. And healthcare is a very personal public trust issue. And as a result, for-profit brings in the wrong motive in this case, and we want these institutions to be not-for-profit. Last week, if you think that's not true, 2 weeks ago I was on LinkedIn. Blue Shield actually had one of those polls, and their poll was asking the question of, do you think that it's important for Blue Shield to be a not-for-profit? You ask yourself, why would Blue Shield ask that question about what people think about being not-for-profit or for-profit? And so the second thing that's a problem is that there is no standard way of accounting. For example, we talk about things like GAAP. As a result, we're able to compare things pretty much apples to apples. Right? We could argue on the finer points of analysis on whether GAAP is GAAP or not. But in the not-for-profit space, there's nothing like GAAP. You could have a $50 billion not-for-profit that is not even required to audit their financials. As a result, some of the things of why you want to be for-profit or not-for-profit is that when you're not-for-profit, you can go back to the old days of having zero accountability around how your dollars are actually being used. What's even more interesting is if you actually look at most states, for example, in the US and the federal government, you'll find that they have a charity test that has to be passed as a result of, and that's the way that they maintain their not-for-profit status. So a couple of interesting Illinois examples are Provena Health and Carle Foundation Hospital, which I'm sure if anyone's been through Illinois, remembers Carle Foundation Hospital. Both of those hospitals are not-for-profit foundations, if you will, that run them. And both of them have been sued by the Illinois Department of Revenue around their tax status because they spend less than 0.5% providing charity care to pass their charity test. Okay? Now, there's an example of another very large provider that provides about 4% of their revenues for charity care to pass the charity test. One of the important pieces that everybody's missing is asking the question, well, where is that 4% coming from that's being used to provide charity care? That 4% is coming from the 100% of revenues that are being collected from the members who are paying for the service. And that money, then 4% of that is being used to provide charity care so that they can retain a charity status, not-for-profit status. And at that point, you've got to ask yourself, maybe we're engineering all of our for-profit companies incorrectly and we need to convert all of them to not-for-profits. And then the third reason that we see is that there are a lot of government and industry association gatekeepers, right? When you go back and ask the question of, in California, or actually across the United States, until a few years ago, only a physician was allowed to administer an injection. Now go back and ask yourself, what does going through a cadaver for 4 years and everything else they've done in medical school have anything to do with their ability to do an injection or not? It has nothing to do with it whatsoever. It was only a few years ago that a nurse could actually give an injection. And a few years after that, now we've allowed folks even like pharmacists who've gone through 3 years of school. But now if you were to go back and ask yourself, could we train a monkey to administer injections and give immunizations? I think I'm fairly certain that we could potentially do that. And the point I'm trying to make is that a lot of healthcare, the way that we deliver those services, we're not asking the question of what's the most efficient way to deliver that service. We're asking the question of, given the legacy of where we are, given the politics of who wants to do what, given our large union-like organizations that run a lot of healthcare in the United States, in that context, what's the way to deliver healthcare? And as a result, an immunization that takes 1 minute and requires 0 training, or maybe an hour of training, costs $85. So there are a lot of these reasons too, in that we can't commoditize the cost of the delivery system. So another way to think about that would be, if we were to go to General Motors, right, and say that, you know what, every person who screws nuts and bolts on the car, they require PhDs in operations research. Now all of us would look at that and say, that's the dumbest thing I've ever heard of. But every day in healthcare, we do exactly the same thing. Because we have the equivalent of the PhDs in operations research, we're doing things like administering injections, right, which raises the cost of the delivery system. So who can solve the problem? Well, money talks, right? And ultimately, this is all an economic problem. One of the things that I want to point out is that we haven't talked about healthcare at all, if you've noticed. And that's actually what's different about what we've been focusing on, is that we don't think that America has a healthcare problem. We think America has a problem with the business of healthcare, which are two different things. And that's the piece that needs to be fixed. And rather than having a discussion about the business of healthcare, we're usually having a discussion about healthcare itself. And that's the wrong discussion to have. So the largest payer groups in the US are the government, large self-insured employers, and employees. So if you were to ask the question of who has the scale to solve this problem, those are the 3 groups of people. And so if you were to ask yourself, how do I make a change? Well, it's going to have to be through one of those 3 groups of people, right? Whatever that change is that comes about. Because if you ask this question and ask yourself, well, where have we turned to solve healthcare problems? Where has Washington turned to solve all of our healthcare problems? And who are the people on all of the commissions that are serving to solve healthcare problems? Well, they're people who are in healthcare. How are people in healthcare compensated? To reduce the cost of healthcare or to increase the cost of healthcare? So, does that make too much sense? So this is a book that was put out by the CEO of a not-for-profit hospital, and I think he said it best, in where he said that healthcare will not reform itself. And so the first problem is that we're asking healthcare to solve its own problems, where healthcare has 0 incentives or has disincentives to solve this problem. And what I love about this guy is he's an honest guy. Because he's the head of a not-for-profit hospital, and his salary is about $8 million a year. And so when he says that healthcare will not reform itself, he means that experientially. And one of the other problems that we have with healthcare is that we don't constrain what we mean by healthcare and what can be done. This is a tobacco smoke enema. And you can read the description of how it was used back in the old days. And this is where the term blowing smoke up one's ass came from. And we have a lot of that going on in healthcare today. All right, and then the other the final question that we should ask ourselves is, are these problems too complex? I would argue that these are napkin problems, right? These are napkin problems that we've solved in every other industry, right? But we want to make them complex, or other folks, for example, have an incentive to make these highly complex problems. And ultimately, they're not unlike any of the problems we solve in every other industry. If we could take the healthcare hat off for a moment and look at it like any other business or industry that we've been successful in commoditizing and reducing the cost of, then we wouldn't have difficulty at all dealing with this problem. And that is the end. So if you have any questions, a few minutes for questions.
So I wanted to say thank you for an excellent talk. The other thing that I wanted to say is that I've been looking at this healthcare record stuff, electronic healthcare record security and privacy, and almost everywhere I look, the system is actually built for billing. It's not actually built for diagnostics or diagnosis or anything. So, the money is clearly in the system itself.
Alec brings up a really interesting point. It was, if you remember, with healthcare reform, right prior to healthcare reform, the HITECH Act was passed, if you remember HITECH. And as part of HITECH, one of the things that we, in our infinite wisdom, had discovered was that paper must be the problem. If we were to move from paper to electronic records, that would solve all of our problems. And so we decided that we as taxpayers would subsidize about $18 billion of electronic health records. The one thing that folks in Washington forgot to ask the question of, hold on, these hospitals that aren't on, that are all on paper, what's the one part of every hospital that's not on paper? It's completely electronic.
Billing.
There you go, billing. So they were smart enough to figure out that billing needed to be electronic, but not smart enough to figure out that clinical care needed to be electronic.
There have been reforms trying to create a competitive model of some sort. The HMO was one attempt, and that obviously failed. I mean, it seems to me there are some aspects of the healthcare market that don't lend itself to a fully competitive market. You can't judge quality until it's too late. You mentioned one at the beginning, but you didn't talk about is complete lack of transparency. You have no idea what you're buying. And then, of course, the third-party payer. Why do you think trying to get more competition won't just end up going nowhere?
Because, the example I would use would be for every other industry where, if you look at how healthcare services are bought and sold, you have the contracting piece of it, right? Where some contracting agent, whether it's a government or self-insured employer or someone, buys a contract. But ultimately, the cost is not in the contracting. The cost is when a consumer makes a decision to acquire some product or service within healthcare. And so ultimately, if we can't get consumers to make choices in the same way that they do, and we try to create a system that goes against how consumers make choices in every other environment, we will fail.
Right, I mean, it's a free good, you get over consumption. All you have to do is go stand in a CVS drugstore, and any time of the day there's a line 10 deep at the pharmaceutical counter. Now, that also reflects consumer attitudes that, we can eat whatever we want, we can smoke whatever we want, we can drink whatever we want, and then we go get a pill to fix it. And I mean, to me, that's an issue as well, just overconsumption and expectations out of whack.
So there's no question about it, right? There are behavioral issues that drive up costs and everything else, and there are issues, what should we cover, what should we not cover? You're absolutely right. But is there one thing that we can agree on? That we should never pay more than what the intrinsic market price or cost is of a good. Can we at least agree that we're not going to pay $30,000 for the same, labor and delivery that's $4,000 over here, right? We can argue about which services should be provided, but can we at least agree that we shouldn't overpay for the services that are provided?
I think you've got to unblind a lot of things before you can be able to do this. For example, if you need surgery, you can't go into a hospital and say I need surgery. The doctor has to recommend it. And the doctor is only on the staff of 1 or 2 hospitals. So if he's going to do the surgery, you're limited to what hospital you can go to by what staff he's on. And then you find out the doctors own the hospitals anyway. So you got to unwind a lot of things.
So one of the ways that some of the folks have started, like for example, CalPERS, which is the California Public Employees Retirement Benefits and Healthcare Fund. One of the things that they've done is they looked at hip replacements because they have an older population, for example. And last year they found that there was a spread of between $17,000 to $100 and roughly $20,000 for exactly the same hip replacement. Exactly the same. And this is what they paid for exactly the same thing. So what they decided in this case was to come back and say, we're only going to pay $31,000, which is the average. Now, there are definitely some issues with use of reference pricing. But basically what they came back and said was, it's fine. You can choose to go anywhere you want. We're not going to tell you where to go. All we're going to tell you is we're not going to pay over market for that. And we think market is set by the average. And at that point, if you choose to go to the more expensive place, just like you would make a choice to buy a more expensive car, that's your choice. But somebody else shouldn't have to pay for it.
How does the consumer even know what the more expensive place is?
Yeah, that's the
So, I mean, part of the issue is that there isn't a lot of information, and those are some of the areas where there are a lot of opportunities for improvement on. You know, there are companies like Castlight and other companies that are focused on providing some of that information to the consumer. And in the case of, for example, like CalPERS, they're providing that information to their members so that they have that pricing information.
You kind of talked high level about a lot of these issues, but if you talk to hospital people, and I'm no expert on this, but you have this huge Medicare and Medicaid issue where they have tons of people coming in. The hospitals don't make any money on these transactions, and so they transfer the profit they need to make onto other transactions. So you see this, depending upon what bucket you are in when you walk in the door, it's responsible for the different pricing that you get. And so, you know, if you're the Medicare, you know, you're coming out of Medicare or Medicaid, you're paying here. If you're coming out of a large employer group, you pay here. You come in off an insurance company individual policy, you pay here. You come in paying cash, you're paying through the ceiling. And it's also the hospital can make up for where they're not getting paid somewhere else. This is a big problem. How do we deal with this?
I would actually turn the whole problem around and ask the question of, well, what would we do in any other industry? You would have to find innovation to figure out how you're going to lower the cost of the delivery system, right? By us allowing subsidies to occur, we remove the pressure that would drive optimization within an industry.
Run that again slowly.
I'm sorry. By removing those pressures, for example, if this patient is a Medicare patient who only pays half, then their problem is that I've only got half the number of dollars. I need to figure out how to deliver that service with half the number of dollars. In every other industry, that's what you'd have to do. You don't have the luxury of saying, you know what, I'm going to charge this much, right? And this person can only pay half. Well, when somebody else comes through, I'm going to go ahead and charge them the delta. You don't have that luxury. In every other industry, the only luxury you have is of saying, well, I need to figure out a way how to deliver that service at half the cost if I'm going to remain profitable. And we need the same sort of pricing pressures within our hospital system. Thomson Reuters actually publishes a report every year of hospital profitability, even though most are not-for-profit. And so they actually have come up with some metrics around overall metrics for hospitals in the United States. Last year, the average was that hospitals, and again, remember, hospitals don't have any standardized way of assigning costs. It's up to them to determine what it costs to provide a service, right? And so they themselves had determined that their operating margin was minus 5% on the public side of the business, or this would be Medicare, Medicaid, and everything else. The profit margin on the commercial side of their business was plus 30%. Okay, so what Medicare and Medicaid have tried to do is that they've recognized that there's a problem with the economics of our industry. They've tried to fix that by saying, we're going to put price controls in place. All right? And so they do that. Medicare, Medicaid, drugs, procedures, there's price controls in place on what will be reimbursed. That strategy is only effective if you can prevent cost from shifting. And Medicare has absolutely no way, as you just described, that's exactly what happens. And unfortunately, that results in a system that benefits nobody, right? Other than the people who pay. Who pays the commercial side? All of us who are employers and employees. Who pays the taxes that pay for the other side? All of us who are employers and employees, right? So we get to pay for those on both ends of that.
So you're saying, okay, so on to just one other. You talk about competition, bringing competition into this. Obviously, you talk about markets where there isn't competition, but there have to be markets where there are competition, and there have to be, who are the healthcare providers that will be for-profit healthcare providers who are driving this process right now? There have to be people that are looking at this saying, I can cut this out, I can cut this out, I can cut this out. Who are these smart people?
But what incentive would they have to do that?
Well, what about on the drug, that chart you did on drugs? Why isn't there, I know they're internet providers of drugs, why doesn't one of them look at that rock bottom price and say to his customers, I will pay you $5 per prescription for the right to refill your insured prescription?
Because again, if you look at how these industries work, we have third-party payment yet again.
Yeah, but you just give a cash refund to the, CVS gives you a coupon worth $10 on anything in their store if you walk in the door.
So the answer to your question is there are many ways to solve this problem, right? But the problem is ultimately, until the buyers know that there's a problem, they don't know.
But I would think, anyway, look at this. I looked at that and said, gee, there's an opportunity there. Why don't I start a company? And the question is why hasn't that happened?
I'll give you an example of why that hasn't happened. You remember Walmart about 3 years ago? I'll get to your question in a second.
Yeah.
Walmart 3 years ago started a $4 generics program, right? And so they're the equivalent of, remember on the chart, there was the $4 for the prescription versus the $60 for the prescription? I talked to the guy who heads that business up a few months ago, and he told me that Walmart considered that a failure from a market perspective, okay? And if you ask, well, why is that? Well, it's for a really simple reason. What's Walmart's model? Walmart's model is to go into any market and commoditize the back end, and therefore resulting in the lowest prices on the front end for any good or service. So they went into healthcare and decided they were going to do exactly the same thing. As long as they commoditized, people will come, right? So they took those prescriptions that people were paying $60 for, and they made them $4. And they publicized everywhere that they're $4 generics. Well, what's broken about the system? Well, most insurers, employers, government, everyone else work through plans. Plans have things called copays. And so what was happening was that, well, what's your copay for a generic drug? $4 or $5, or maybe it's even free, right, for most employers because they want to push you towards generic drugs. And most employers don't want to say, you can only go to Walmart, for example, right? And as a result, what ended up happening is the consumer's making a choice between, do I pay $4 at Walmart, or do I pay $4 on my copay? And they chose I'm not going to drive 2 miles extra or 4 miles extra to a Walmart to pay less because I paid $4 in both cases.
Yeah, but why doesn't Walmart give them an incentive? Pay them to come bring the prescription in or give them a coupon.
Yeah.
Charge $10 for it and say,
because
we'll give
then
you
the
$5 back.
FTC will be on Walmart's back talking about anti-competitive practices.
I don't know. I mean, you're just starting. Obviously, someone has to give the consumer an incentive.
Yeah,
and
no,
no one's
absolutely.
going to do it as long as there's a third-party payer.
I'm sorry, go ahead.
So, if you end up going to, okay, if you're right, how do we get there, right? Talk about a lot of innovation around information, even in the pharmacy area. There's all kinds of business people who are trying to solve for sort of incremental savings. But when you get to a hospital where a lot of big money is, right? Some of these things are also natural monopolies, right? Because you've got a lot of capital, you've got these buildings, you've got all this equipment. There's actually some natural monopoly characters, not just non-profit things, right? So it makes sense to have a few hospitals, not thousands of hospitals. It reminds me of telecom, right? You made this massive investment in telecom, and ultimately the government had to come in and break that up, right? And allow people to carry their systems across other people's pipes and do all that kind of stuff. So, this is where the rubber meets the road, right? A lot of what you said makes sense to me, but sort of how, right? When you go to the hospital, how do you break up these monopolies, some of which are sort of natural, but in other cases you've got true monopolies. There's been consolidation. You've got doctors that are say joining these hospital groups, etc. The employer can demand whatever it wants, the consumer can demand whatever it wants, but at that hospital level, doesn't the government have to basically, what's your conception of how that actually happens? How these monopolies get broken, how you introduce competition?
So, I mean, the answer to your question is, where should this problem be solved ideally?
Yeah.
Washington. There's no question about it, right? It's a structural problem within our economy that's driving this. That's what Washington should be focused on.
So who's going to drive that? How do you see that happening, if you see that happening?
I don't see that happening. I see that as the healthcare train has left the station and is going somewhere else. And it's not towards dealing with the real issues that are the fundamental structural issues that drive cost. So at that point, the only parties that, realistically speaking, that you have left are large employers and employees, because they're the only groups of people who have any sort of incentive, if you will, to do something differently.
And CalPERS can't create hospital competition. They can only set limits.
Well, you know, one of the things that they're doing, a lot of high-cost things are elective, right? Your stent, for example, or your hip replacement, or those things. And so what CalPERS is doing is increasing sort of the geographical spread associated with what someone can go. So they've removed that location dependence, right? To say that, well, if you need emergency care, you go to an ER, but if you need your hip replaced, that's not an emergency, right? And at that point, we can pay you to go to Southern California. We'll put you up in a hotel, and you'll pay less.
So even though your conclusion is it's got to get competitive, you don't see a easy or natural way to introduce that other than through all these little things so slowly.
So the number one biggest way, government, no question about it. Let's put government aside for a second. If you were to ask, well, what are the other ways? Then it's got to be private sector, right? And the only folks right now who have an axe to grind, if you will, of grinding down prices are large self-insured employers who bear the brunt of healthcare costs. So they would be the natural drivers of healthcare. And you know, we face another conundrum also. How is public policy made in the United States? Well, it's usually driven by special interest groups and lobbies, for example, that represent some group. And so the problem ends up being, well, what's the largest sector of our economy? Well, healthcare is the largest sector of our economy. Where do you think a large number of lobbying dollars come from aggregately? Well, they come from healthcare, right? And when you ask the question of, well, but everybody else is the recipient of sort of those things that are occurring as a result of those special interest groups potentially. Well, the problem is that there are no aggregate groups because, for example, if I'm in oil and natural gas, I don't lobby against healthcare. I lobby for oil and natural gas. As a result, there are no groups that are actively, if you will, asking the question of, well, who represents the American people? There is no lobby that represents the American people, right? So in our system, it makes it very difficult to solve these types of issues also as a result of our political process.
So what if we took the battle to the consumer, right? I mean, I think it's a lot about misinformation and not being educated about this stuff. Like, you know, what if we had an Occupy, you know, the hospital campaign?
Occupy healthcare?
Yeah, Occupy healthcare. Like,
idea.
what would we tell people, right? You know, what would we tell the average consumer? What could the average consumer do?
Let me ask you a question, though. What decisions are you going to make differently as a result of this information? Let me tell you a story. In December of last year, I ended up at Stanford Hospital because I was having chest pains. Now, in retrospect, I've been to an ER twice in my life. Both times it turned out I was there because I was on, first time was a statin, the second time I was on niacin, and I had an adverse reaction. And both of those are designed to prevent me from ending up in a hospital, are the two reasons why I ended up in an ER twice in my life. So I was at Stanford Hospital. I, went through the whole process. I spent 14 hours there, or 13 hours. The bill was $26,000, okay, for a 14-hour bill, for a 14-hour stay. And so I'm a little bit familiar with the whole process of how hospitals work, risk assessments, those types of things. And so when I walked into the hospital, they had done an EKG. So that meant that I wasn't having a heart attack at the moment that I was in the hospital within 5 minutes of getting there. And they'd also done a troponin test, which also indicated, which is a gold standard for if you had any sort of cardiac issue, within less than 30 minutes, indicating that I had not had a heart attack before I walked in either. Okay, so it's ruled out that am I having a heart attack or did I have a heart attack? At that point in time, Stanford Hospital should have said, you're not having a heart attack, go home. That's not what happened. 4 EKGs, 4 more troponin tests. The list goes on and on of all of the different things. They did an stress echocardiogram, which I didn't have to do right then. Right, could have done that when I went home. So the bill was $24,000, and so I, called up our health and benefits people and said, "Hey, what's up with this? I'd like to file a grievance against Stanford because I don't think it's not about the money. It's about even their therapy from a protocol perspective absolutely makes no sense. They're supposed to be the premier hospital in this area." And so they're like, "Well, we don't know what to do with that. We've actually never had someone call up and say, we've paid too much." We always get people who call and say, "I was denied coverage." So then they didn't know what to do. Finally, they call up the insurance carrier, and I call up Aetna's, it was at that time, I think we were with Aetna, or no, it was Anthem. And called up their grievance department, and they're like, we have no idea what to do with your claim because we're a grievance line. We are called when people are denied claims. And I said, you know what, I get that, but I'd like you guys to file a grievance with Stanford. And so they file a grievance with Stanford. I hear nothing back from January to September. At the end of September, somebody calls me back and says, hi, hello, I'm from Stanford. I'm like, well, okay. We've decided that we're going to write off the portion that you owe. And I said, you know, I'm very grateful. Don't take me to be an ungrateful person when I say this. I thank you very much for the fact that you wrote off the part that I owe. But my employer paid 9 times what my liability was already to you for this. How about my employer's liability? And this case can't be closed until you come back and explain to me why this was the right therapy and why my employer paid 9 times as much for this as what my liability is. And she was shocked. She didn't know what to do with it. And I was like, okay, go back to your, and I asked, well, why can't you tell me? Well, we've contacted the emergency department many times and we get no response from them. This is billing at Stanford, talking to the ED department at Stanford, and they can't get a response from them on why this was charged and why this was the correct therapy. And I had to leave it with the, well, I'm sorry, but I can't consider this case closed until you come back to me with an explanation for why and why these were the right charges. The reason I bring up that story is that while it's true that we need to change a lot of things in government and everywhere else, the problem starts with each one of us, because we go home with paying the $60 for the drug and we're okay with that. You know, we go home with we don't call them up and ask them, why did you bill me for that? Why is this bill representative of the right therapy care that I should have received? You know, we don't do any of those things. So the first thing I would recommend is that we need to start with ourselves, who are more educated about the problem, to start thinking differently and doing differently. Right? That's the best place to start action, if you will. And then it raises the question of, well, what can we do more than that? Because we don't want just ourselves to be different, but we want structurally changes to occur which are beneficial for us. And frankly, the reason why I posed this around the problem space was that there are a lot of smart people in this room, right? And what smart people do are come up with solutions to problems when the problems have been identified properly. So the hope is that with you getting a better understanding of where the issues are, that some of you will go out and come up with some creative ways of solving some of these problems, or starting to chip away at some of these problems.
One solution when they were debating national health care, and by the way, the best way for the corporations to deal with this is dumping on the government. but
no, it's not, because remember, what's that one line
tax.
that none of us pays any attention to where our money goes? It's called taxes.
Ostensibly it is. But the was this proposal that instead of the government paying, you know, being the single payer and all the rest, was that they simply give you a coupon worth X dollars and let the consumer go out and buy their own insurance plan. What do you think about that?
So when you look at, for example, the healthcare exchanges and buying insurance plans and what our whole program is around healthcare exchanges, you have to understand the way that insurance works. It's a zero-sum game,
Yeah.
right? It has actually nothing to do with the cost of insurance. It has to do with utilization of benefits, right? And so the only way to lower the cost of insurance, or how much it costs on average to insure someone, is to either reduce the benefits, right? Reduce what we'll pay for, or second, to reduce the cost of the goods and services that make up whatever that person's utilization of. If you don't do one of those two things, which are really about the supply side, they're not about acquisition of insurance.
Right.
The insurance is irrelevant. All we're doing is moving money from one bucket to another. Ultimately, the issue is we have to pressure the downstream.
Essentially, though, the idea is the insurance carrier would be the buyer who would then have this pressure because they couldn't just keep pumping up rates to get out there and make a deal with Carl or somebody for fixed fees and more efficiency. And
so last year there was an issue between United Healthcare and Oakland Children's Hospital and Lucille Packard. The contract dispute was over the fact that United Healthcare was actually reimbursing Lucille Packard for exactly the same procedure at 2x what they were willing to actually pay Oakland Children's Hospital. And so the contract dispute was between Oakland and United Healthcare with, well, how could you explain that, a few miles away from where we are, you're willing to pay 2x as much? And it's for a really simple reason. It's that everybody wants, in the commercial sector, Lucille Packard in their network. My second son was born at Lucille Packard. Not a lot of people care about Oakland Children's Hospital because it has a lower ratio of people who are commercially insured versus the government. As a result, it's a question of who has the power to set pricing in this arena. It's not the insurance companies. The insurance companies actually have no control over pricing at all. It's the folks who control the products and services. And when the commercial sector says, I want Lucille Packard in my network, or you're not going to have a plan without Lucille Packard in my network, at that point you see these sort of anomalies where the providers set pricing, and there is no competition around that.
Will you share your slides?
Pardon?
Will you share your slides?
Yeah, absolutely. Anyone, by the way, not only am I willing to share the slides, it's sort of like an open effort. Feel free to pass them along. Feel free to improve them. Feel free to use it. Don't really care because, all of us have a common objective of doing something about solving. This is not my problem or your problem. This is everybody's problem.
The part B of this was, are Medicare reimbursement codes the lowest or approximately the lowest cost?
It depends on your definition of cost. So if you mean price or reimbursement, typically they're lower than commercial. Medicaid is typically even lower than Medicare. But remember, Medicare doesn't cover every procedure because most Medicare folks are above 65. And there are some other folks which within, under, but those are usually, people that are
what
covered.
it covers.
Yeah. And there's a lot of variation there. If you were to look at a hip replacement, for example, in last year's data for Medicare, you'd find that Arkansas has the second highest cost for a hip replacement. And you're like, what about Arkansas? Right? The second highest cost for hip replacements. Right? Is it geographic? And I don't really know the answer to that because, again, we've seen aggregate pricing, haven't really looked into why, don't really care. But ultimately, if you were to ask the question of, well, where are the cheapest places for that hip replacement in the U.S.? Well, you talk about medical tourism, and you don't even have to leave the U.S. If you were to go to Guam, U.S. Virgin Islands, or Puerto Rico, it's approximately 40 to 60% less the cost Medicare to a hip replacement. So we should be sending all of our folks for a nice vacation to one of those three places.
Going back to about the government trying to fix problems, if you will, isn't it true that a lot of government officials serve on board of directors for hospitals and things like that?
Yes, that is a problem also in that when you look at a lot of these there's an interesting case of a well-known not-for-profit in this area, and their board of directors at a not-for-profit are compensated over $235,000 a year for 6 hours of service. So when you look at some of those institutions, you also understand why there's less of an incentive, and it looks more like the for-profit markets, if you will, versus the not-for-profit markets. And you also look at how these structures work, and you realize under the hood, they operate like for-profit companies in every way, even at the board of directors level.
So back to your hospital visit. They ran 2 tests, and you said they should have sent you home.
Yes.
But then they kept running tests. If you had gone home after that and had a heart attack within an hour and died, well, they would have wound up in a suit. And that's one thing we just haven't talked about today. There's a lot of repetitive testing, over-testing to cover this. How much does the legal environment and over-testing out of fear, which I think is kind of what happened to you, play into this?
Actually, let's rewind that for a second. The estimates on the cost of tort are less than 2% of the budget.
But that's the estimate of, now is that an estimate of actual legal damages and settlements? Or does that include the cost of all the, I think there's an over-testing.
No, hold on. That includes the cost of the actual tort. Now, if you were to ask the question of what evidence do we have that people actually over-test? Actually, we don't have any facts to support those assertions.
But you don't believe that?
No, I have to tell you, no, I do believe that. And why? What I saw at Stanford, I'll tell you my own experience. If I went in thinking exactly what you were thinking, that this is an organized effort, for example, to drive up the revenues by additional testing. I have never seen a more disorganized group of people in my life. There was no way that that was an organized effort to drive up. That was so disorganized. It was random people walking up to me every hour or so, random doctors, random nurses, asking me the same questions over and over again, even though they are on Epic, which is the premier electronic health record system, and they were extremely disorganized. So if they were able to actually construct a plan whereby they had a revenue generation opportunity by over-testing and reducing the risk that way, it was not apparent because they hid it well in their disorganization.
So how does McKesson make money or play into this problem? What's
well, you know, it's
you've identified the problem, not the solution that you're proposing.
Well, we have some solutions that we're working on, and for a lot of reasons, being a for-profit company, we can't talk about it. But you know, the thing that we can agree about is that at least all of us should be on a level playing field on what the problems are. And we've obviously got some spins on some things that we're working on that are related to solving some of these issues.
And
but the answer to that is yes, of course.
Will those innovations be possible under Obamacare?
Yes, absolutely. The critical piece is not, you know, what the constraints are, but to figure out how do you get around those constraints.
You showed that interesting chart about the U.S. versus other countries in terms of healthcare spend per GDP. Is there any relevant case example of another country starting with some of these issues that we're talking about and subsequently fixing any of them that could shed some light on what we should do?
Well, you know, you bring up a really interesting point, which is that this isn't an issue where someone planned to screw the American people, right? That's not how this evolved. This is the legacy of a lot of decisions and things over the past, you know, 30, 40, 50, 60 years. And the result of all of those quote-unquote random actions has resulted in where we are. It wasn't a planned activity. So one of the reasons why we have the issues that we do is that we have the longest legacy of a healthcare system. So going back to your telecom experience and everything else, it's the same legacy problem that we have in healthcare, that we have in telecom and all of these other areas, and that we have the largest amount of installed infrastructure in all these spaces. If you were to ask the question, hey, today, if we were to start at a green field, would we do things the way that we do today? The answer is, of course not. Of course we wouldn't do it that way. And so the problem ends up being that most of the other countries in the world don't have a legacy problem the United States does. So it's starting at a very different point than we are. And so it becomes very difficult even to compare the two because they don't have a legacy problem that we do.
So how do we create transparency?
You know, there are a lot of companies working on transparency-related solutions. So, I mean, that's a start, but I would go back to, I would ask you that question. So how do we create transparency? You tell me. What should we do?
Well, why don't we just get rid of the profit?
That would be a great start. You know, even if we couldn't get that through Congress, maybe the thing that we could get through Congress would be, can we at least agree that there should be the equivalent of GAAP for not-for-profits? Right? Maybe I don't think we're going to get the American people to think beyond the for-profit versus not-for-profit, but maybe we can get people to agree that at least we should have the equivalent of GAAP for not-for-profits. And that would be a start.
So we could have random auditing in health records.
Yeah.
You know, we could look at, you know, who's overpaying, you know, was that really necessary?
Yeah.
Now, the dilemma you have, though, if you start, you know, this is the counter argument to transparency. You say you start publishing outcomes and costs and stuff, you know, some of the best doctors may always be getting the worst patient because they're the best doctors. And I know in my business, you know, the better you are, the more you get the defendant who's really screwed up.
Well, you know, I agree with you. I think, but we have to be careful of, you know, we also use outcome as a shield.
Yeah.
Right? Because we start talking about that term. Why we use the example of the labor and delivery is that, well, it's 50% of all transactions that occur in healthcare, right? And they've already coded it as everybody was happy. What's wrong with the outcome?
Yeah.
Can we argue about the outcome there? Which doctor was better? I don't know. They all sound fine to me.
How about standalone maternity?
Well, you know, the first thing that we thought of, as you probably thought about, was, well, why don't we build standalone delivery centers? The reason that you can't is because if you remember a few years ago when the surgery centers were opened up, remember all the doctors moving to surgery centers, the American Hospital Association legislated a law that prevents the opening up of these other service centers because they said it took away the profitable procedures from the not-for-profit hospitals. So that's the reason why we're constrained suddenly and prevented from coming up with a better delivery system.
Just wanted to make a quick comment. There is a group at Stanford that's actually interested in Occupy healthcare issues and the like.
We're a for-profit company. Okay. We're not into Occupy.
No. No, but they have a slightly different.
Why people occupy? What are you talking about?
They have a slightly different focus. So I was at a rally last week, and they basically had what they call a teach-in, and they were teaching about healthcare and inequality and how the poorest people have the worst health and the wealthier people have better health. But no one really got into the details of the billing mess and the incentive mess. I mean, I think that they're probably looking at maybe some of the wrong issues, or maybe from a different perspective than what is required to actually fix the real problem.
You know, that's an interesting point also. When you look at actuarial risk, which is really the proportion of what your projected insurance coverage costs will be, there are two main things that drive your actuarial risk on an individual basis, or your age and sex. The third axis that's actually interesting is income. There's an inverse relationship between income and spend on healthcare. So absolutely, people who make more money spend less money on healthcare and are healthier in general. And so, yeah, you're absolutely right. There are definitely some inequality issues structurally also that need to be taken care of.
That's their main problem. That's what they're focusing on. You know, they're not looking at the structure of the industry itself, which I think may not necessarily be the most productive way to fix healthcare, or the business at least.
I make this a stopping point.
And since I have everybody's email address, I will send out promote slides to everybody later this afternoon or this week. So thank you.